the K-wire fixation for extra-articular fracture of the hand. The strategy for the fracture in the hand includes no surgical treatment, and the surgical treatment is well known. The surgical treatment include K-wire, using K-wire, plate screw system, and external fixation. The external fixation is usually used an internal fixator. So my procedure is just as an alternative, not a recommendation for the treatment. In the treatment of the fracture, there are infinite weakness in the design of small devices, such as external fixation, the external fixator. They are difficult to be assembled and difficult to be adjusted after application. So usually maximum of 4 pins or screw can be installed in a usual external fixator. So alternative option is, in this case, the shaft fracture of the medial phalanges. Medial phalanges. It's an unstable fracture. The patient is 35 years old male. The procedure is as follows. First of all, we use the axial K-wire to stabilize the fracture after reduction. It is an axial K-wire, and then we confirm the reduction of the fracture and X-ray, and then we insert 2 to 3 K-wires at each end of the main fragment. It should be noted that this is a safe position, safe area for insertion of the K-wires. There's no tendons and neurovascular structures there. So we confirm the position of the K-wires, and then we bend the K-wire at about 1 to 1.5 centimeters distal to the skin and towards to the opposite side, distal to proximal. And this shows the K-wire position and the reduction of the fracture. Then we use the cement to run over the K-wires. It's used as an external fixator. It's just like a smart fixator. Then after the cement is solided, then we remove the longitudinal axial K-wire that we check the range of motion. You can find no K-wires involved in the articular surface. It's a range of motion immediately after surgery, flexion and extension. And we use a splint to protect the fixation, just to protect the fixation and bone healing after 4 weeks. It's a series of cases. That's the measurement and the results. In comparison to their normal size, this is almost normal range of motion. It's after 2 years, it's a range of motion almost normal. It's some pairs and pits for this technique. Let's say traditional K-wire is cross figure K-wires. And this is our technique. And let's say in the community fracture, we use the more K-wire to reinforce the fixation. You'll note this K-wire's position, direction of the wear position. We can insert this, note this position and this position because it's produce minimal impingement for the skin during range of motion. It can reduce the pin track infection, the rate of pin track infection. And in another case for the proximal phalangeal, there's a fracture. It's not a stable fracture. We use a similar technique. First, insert extra longitudinal K-wires and check the reduction of the fracture. And then insert K-wires just like this, from distal to proximal. And this is one position on the lateral views. This is AP view. And this is wear position. And then we bend the K-wires and cover it with the cement. After solid, we remove the edge K-wire. You can see the reduction and the wear positioning and the bone healing after 4 weeks, and the range of motion after 1 year. It's another case for the first metacarpal fracture. It's close to the base of the thumb base. It's also unstable fracture. So we first inserted the K-wire similar to those case previously, and then transverse K-wires. And bend the K-wire and cement it. This is the AP view, lateral view, and we check this position. And after 4 weeks, you can see the bone healing and the range of motion up to 1 year. This is some technique we should note. If the fracture is located at the most distally, we use the K-wire at this position. This allows early range of motion without impinge to their skin, without impinge to the articular surface, that will reduce the risk of pin track infection. And it's a cement. It's another pattern of fracture. It's an oblique fracture, long oblique fracture. We use K-wires in this pattern and additional K-wire to close both distal and proximal fragment that will reinforce the fracture. There's another pattern fracture. This bad fragment. We use this K-wire, additional K-wire to reinforce the fracture. And this picture shows the third and fourth metacarpal. You know, we cannot reduct it directly manually because it's some adjustment. If the adjustment metacarpal is intact, so we use this hook technique, continuously inserted into the skin and just hook the fragment on the opposite direction, then we can achieve a reduction. This is one of the technique, continuous technique, and it's another technique for joist, for leverage technique. So you can make a great force to reduce this reduction. And this is joystick technique. This technique is very useful for competence reduction for this fracture. indication for technique, almost all pattern of the shunt fracture of the middle and middle phalanges, proximal phalanges, and even metacarpal metacarpal fractures. And the contraindication include relative contraindication including articular fracture because the articular fracture requires more current reduction, and advantage of almost a smart internal fixation system is a smart internal fixation system and a minimally invasive procedure, a rigid fixation that can control shortening and rotational deformities. The fixation allows early joint motion exercise, which is result in good hand function. This advantage of technique included inconvenience of the cemented frame for the patient's daily life, this may be, and the risk of the intra infection, although this risk is minimal. Thank you for your attention.
Thanks, Dr. Zhang. Any question for
Thank you very much for this presentation. As a matter of fact, I use this technique for 20 years. Okay, instead of putting the walls, use the cement. But I have one question for you. This is actually a modified mini excellent fixator, which I would describe it like that. How would you introduce the hooked K-wire percutaneously when you do your reduction?
I
Make an incision?
no need to make an incision. K-wire, usually 1 to 1.5 K-wires, just make a hook and then insert the skin for canals directly.
But you have the blunt part now in
Yeah.
front of you.
Yeah.
Okay.
Okay.
Small incision?
No small incision.
I have a comment. Indeed, we use this technique not only in the small bones of the hand, but even in the distal end of the radius and the proximal end of the humerus. But instead of using the bone cement for fixation of the wire, we are using the clamps of the rope that catching the pins of the rope. We can use a modified or small parts of it, then insert the outside of the triggering parts of the K-wires into these clamps and close on it. So it is like Victoria, he said it is part of the center, but it is stabilize the outside part of the K-wire and get the same result, but it is without using the bone cement. You got the idea?
All this procedure is in close manner. So the both incision, actual insertion of the K-wire is a relatively easy procedure.
This is we use the same technique, but instead of the stabilizing the outside part of the K-wire by the bone cement, we will see like the clamps of the center hold the K-wire together.
The distance from the skin,
Yes, it is.
yes, usually 1.5 centimeters. So the 0.5 centimeters just for insert the cement, and another 1 centimeters just for K-wire removal. We use the cutter. If you remove this system, first cut off this K-wire one by one to remove the cement, and then remove the K-wires one by one. That's so easy. Thank you.
Thank you.
I can ask you about when movement of finger.
I asked you about with movement of the finger may cause loosening of the wires when active movement from early movement, second day.
Yes.
It's not present
Yes.
in your cases.
As a tolerate, usually second day, require the patient to make a motion within the protection of the slit. This will slit just do the protection for his patients on the vehicles and sleeping, just for this. Yes. Range of motion immediately after surgery is allowed.
Okay, I asked about loosening present in this case, if early movement present, loosening occur or not?
Loosening?
Yes.
Yes. You know, this K-virus is not parallel. It's on an angle. It's an internal system. So, like this, move is difficult. No migration. It's solid, very strong system. So otherwise, you can use additional K-virus, not only 4 K-virus. 4 K-virus can be added.
Thanks.
Can I use some sort of stainless steel sutures and wires to combine the K wires if there is no available bone cement or cement in my hospital?
What?
If there is no cement available in my hospital, okay?
For open injury? For what?
If there is
You use cement to fix the K wires together, combined, okay?
Yes, combined.
Okay.
Always combined.
Can I use some sort of stainless steel sutures or wires as we can use in the ash farm to combine the K wires together instead of the cement?
Yes, it can be used together. It's you know, it's only used for the close injury, but also the open injury, especially in case the fracture, open fracture with cell contamination, and you worry about the infection. That in this situation, plate and screw system is a high risk for infection. Yes.
High risk in cement, but I think in stainless steel wires, low risk. There is low risk in stainless steel wires.
The sensitivity is very strong. You can test it. It's very strong. You can write on over the K bars. It's very strong. So one person should be note that that don't use force to on the K bars. We use this because it's additional stress after you remove the K bar, the fracture will be removed.
I'll add something. In our center, we use a cemented tube, the plastic sheets of the spinal fluid. We use it. We fill it with cement, and after it dries up, we use it as a rod, external rod for fixation of the K wires.
Yes, so use it.
Yeah, this is one issue, and we may use the plastic sheets itself without cement in some cases.
Yes. A key for this is I use only half of the cement. It's a technique. I use half of the powder and half of the liquid, and another just for if there's something difficult, we can redo it. But I never redo in any case. Once time, succeed.
Thank you.
Thank you.
Next speaker.